session that we've got now is collaboration, the answer to our workforce challenges. And of course, we had the workforce plan come out. So really excited about that. And it's got lots of people talking. And I know that Sarah, Angela and Henry are going to give us some really great views on that. I'd like to introduce Sarah Morgan, who's Chief People Officer up at North Central London ICB. Angela Helleur, who's Chief Nursing Officer at South East London ICB. And Henry Black, who's very modest, he's a Chief Finance Officer, and he was saying, well, nobody's going to want to listen to me, but you can throw all your finance questions in the workforce plan at Henry, and he is from North East Central London ICB. So each of them is going to say a few words about collaboration and the answer being the answer to our workforce challenges. And the way we're going to run it is we're going to have Angela go first, then Sarah, and then Henry. Thank you. Over to you.
Thank you, Angela. Two Angelas in the room, a formidable partnership. So, as you say, National Workforce Plan came out a couple of weeks ago now. 3 key actions: train, retain and reform. And it promises all sorts of new training spaces, new access to training, new different ways of training, which is great. I think we have a major problem now, though, real gaps in our workforce. If I talk about nursing and carers, and I think about South East London, actually our vacancy rates in nursing alone go from around 5% right up to 25%, and it's much higher in the care sector. So we do have a real problem right now. And if we think about nurses, we're training all these nurses, but actually when we look at our attrition in the first year post-registration is huge. So there is something we really have to do. And there are pockets of specialisms that are really, really difficult to recruit to. So if I think about those that are so key to prevention, and GP nurses, health visitors, school nurses, actually we have a real problem. So what are we going to do about it? And I think it has to be an immediate issue. Certainly in South East London, we've taken it, and going back to what others have said, we're starting with need and really focusing on those areas where we have these big gaps. And we have really been talking a lot with our workforce and asking them what's going to make the difference. Some of it, yes, is about pay. And those of you who will have been watching the media, I'm sure, over the last almost 6 months and more now with the industrial action, pay is one element, but actually working conditions is much bigger and much more important to people. And having a safe environment. If you look at the NHS survey and you look at the amount of abuse that our staff are experiencing, it's extraordinary. And I can tell you that in some of our providers in South East London, we've had to install metal detectors because of the number of knives and guns and all the rest of it that come through. So having those strategies around safe environments is really, really important for us. I think the other thing to say is making it much easier for people to develop but also work across those boundaries. So again, we've started working with some of our local authorities on some pilots, thinking about how we can upskill our carers, particularly those working in our virtual ward spaces or at home or in care homes, because actually patients we are sending home are much more complex in terms of need. And so really looking at the resource that we have in South East London, which is phenomenal. We have Guy's and St Thomas's, King's, South London and the Maudsley as 3 of our main providers, all with massive resource around education, and bringing them all together and actually working together on education, training, upskilling. Thank you.
So North Central London, which is Barnet, Enfield, Haringey, Camden and Islington, for those of you that North Central or South East doesn't really mean anything, has got the highest leaver rate for nursing in the country. So London and London's the biggest in the country. So we're not in a very good position. And part of that is what Angela's described. Preceptorship nurses can't afford to live in London. So that's a big challenge for us. I think part of that is then how do we collaborate with our local council colleagues and think about the labour markets and our untapped communities in terms of creating opportunities. So for us, our big area is supply, because you can't train them if you can't bring them in. And I think part of that other bit is what Habib said before, for those of you that were here, which was around trust being a net determinant of healthcare. It's a net determinant of our workforce. So what we discovered during COVID was that people actually don't trust our institutions, and therefore why would they want to work for us? So we say we're this great employer, although Angela, I just say you have not been on the PR course for selling the NHS, but actually that's a real challenge for us, because we talk about wanting to have much more diversity in the workforce. We know there are better outcomes for patients, and yet we know that people from our communities have a poor lived experience, particularly in mental health, maternity, and therefore they don't turn to our organisations to work, and they turn to the voluntary sector. And then you bake in pay disparity, terms and conditions disparity, because we think we've got it bad in the NHS. Actually, the voluntary sector does not have a lot of funds to pay their people well either. So, that's part of it. I think the long-term workforce plan is great, but as an integrated care system, it's only one part of the answer, because it's only the NHS, whereas we're looking across one workforce, which is the NHS, so it's healthcare, social care, our voluntary sector colleagues, charities, hospices, but also so in North Central alone, we have 100,000 unpaid carers who are looking after people and basically doing a burden of care, actually, that we don't talk about on a daily basis. So it's incredibly important that we start to think about what is the role of the ICS. And I personally, the reason I was attracted to this role, having been at Guy's and St Thomas's for a long time, was this social determinant of health element, and the fact that we have an opportunity to work towards the economic and social contributions of the fourth test of an integrated care system. So I'm from Blackpool, so when they talked about Hastings, I absolutely get the coastal bit, and I see social mobility for what it was like when I grew up in the 80s and 90s in Blackpool to what it's like today for my sort of nieces and nephews that are there. That has gone away. The social mobility is not what it was, and therefore it's on us to create opportunities, I think. And we are in a great position working with our colleagues, especially in the councils, in a way we never have before, because it's not just about social care, it's about urban regeneration, it's about getting into a completely different conversation. So any council colleagues who want to chat to me about that, I am very open. But I think it's the bit that will make the difference, and it will stop us getting reorganised again in a few years' time, because I think this is our moment.
Thank you. Hi everyone, my name's Henry Black. I'm the CFO for North East London ICS. I've been given the easy task of tackling the elephant in the room of the money, so no pressure there, and wish me luck. So similar to the points that Sarah and Angela have said, the long-term workforce strategy is fantastic to shape our kind of longer-term thinking. But we have a burning platform, and I'm interested in what is the practical application of collaboration. We talk about collaboration a lot around our ICS sort of structures, but what is the practical application, and how is it going to help us in the here and now? So just I guess a few thoughts from me. Firstly, on the kind of the very, very difficult financial environment that we operate within. People will, I'm sure, recognise, those of us who work in the NHS, the probably the most difficult planning round we've ever had, and a lot of focus on integrated workforce activity and finance planning, but a real kind of, for me, an overemphasis on this kind of very simple equation of your hold times have gone up by 18%, but your activity's only gone up by 8%. What's everyone doing? What's the delta of that 10%? You should all be improving your productivity. So that definition of productivity, I think, is a real problem. I think it ignores several really key factors. So we know we've lost a lot of senior staff during the pandemic and post-pandemic. So not only have we got a net increase of whatever it is, 18%, but that's actually a change in the blend and a much less senior kind of cohort of staff. And also ignores the fact that people, post-pandemic, we live in a different world and people don't want to experience and receive care in quite the same way. So using these kind of very crude metrics of hold times over activity, it just doesn't work. I think we need a different conversation about what is the model of care that we need, what are the skills that we need, and comparing that to the workforce that we have. So that kind of definition of productivity and value for money, I just think we need to shift that. The second thing is around changing the discussion about value as well and about cost. And I'm sure I'm not on a commission, I can promise you, but our IQVIA colleagues will be pleased to hear me talking about PLICs, I'm sure, and about how the old ways of measuring value through just kind of price times activity, which was the only metric that we had, and it was all encompassing in NHS planning, and moving away from that to the kind of resources that are deployed on the ground, and how we change the model of care at neighbourhood and place. In order to do that, we need to have a much, much richer understanding of the resources that are deployed on the ground, which we genuinely don't see. Everything is very much through contractual metrics. So using patient level costing, using that kind of local resource deployment view to support a better conversation about value. And then Sarah talked about the kind of the purpose of the ICS and the social value that it generates. But there is a huge financial benefit from drawing a workforce from the local community, improving recruitment and retention. Just the cost of recruitment is massive. And having the kind of better value and productivity in a different way in terms of having that kind of better way of managing our workforce, which will have knock-on financial benefits.
Great, thank you, Henry. I'm going to come to you first, actually, on the questions, and I've got three parts to the question. First of all, what's the practical application of collaboration as opposed to the theoretical? How can we get away from narrow measures of productivity, as the second part of my question? And I know we have a research interest in the room today. As Chief Financial Officer for the ICS, commercial clinical research, both in primary care and secondary care, brings huge investment into those hospitals and GP practices. But it doesn't seem to be on the board papers of what is the strategy for attracting commercial clinical research into the UK. And I'll give you one figure, and this might really shock you. IQVIA bring in commercial clinical research, we've got about 10,000 patients in commercial clinical trials just this year, 2.2 billion of economic investment into the UK. And that gets spread out through the hospital and primary care system. So we're not talking small fry numbers here. Mm-hmm. Never mind mentioning the drug costs that you save when people are in commercial drug trials. And that's not just the medicine that's being tested, it's all the other secondary medicines that go with those. So three questions there, Henry.
Nice and easy to kick us off. So the practical application, that I absolutely agree, that kind of is my mantra. I suppose there's loads of stuff that we could be doing probably better just around some of the kind of fairly simple technical solutions around collaborative banks and harmonising of rates. And those are the kind of the classic things which you would think would be pretty easy to do in an ICS, but believe me, that's not always the case and it's quite difficult. But I guess it's beyond just some of those technical things, and it's much more about what are the modern models of care that we need to design at place, and what do our communities actually want from the health service, which is quite often when you're very ill, it is an institution. But when we're talking about managing people's care and managing people's health on a long-term basis, it is much more about designing a service that is locally and that they can feel an identity with. So that is the practical application, is bringing those partners together at place to do that. How do we get away from the narrow measures of productivity? Well, I guess transparency of data is probably the biggest barrier to that now. I think we have moved from 30 years of the internal market to integration overnight, and have expected everyone to change their ways of behaviour. Now that does obviously, at board level, the conversation has shifted, but penetrating down into the kind of the support teams, it doesn't always happen. So. That I think availability of data, transparency, and a willingness of the leaders of our organisations to kind of free up our teams to share that data and to have a genuine understanding, rather than that's we still have that commercial kind of a sense of competition and a sense of keeping the sort of families, the state secrets. I think your question about research is a really important one, and I think I would probably try and attempt to answer that as a member of a unitary board rather than as a finance director, because as a finance director, it makes perfect sense, and I would want to encourage more of that. There are best practice examples all over the place. I guess it's about what is the clinical case and the clinical support for that? What is the often these things are they kind of build up in a kind of culture over many years and decades based on what is the clinical kind of the consultant body and their view on that. I think as a kind of set of organisations we have to move on from from some of these kind of slightly outdated views around the risk around there's always the risk around IG and all that kind of stuff, but the commercial benefit to the service is something that we have to capitalise on.
And it's not just the commercial benefit. It's well published that hospitals that are research active have better outcomes for their patients
Absolutely,
than those that don't, and the same for primary care. Thank you for taking those three. Councillor Faruqi, you put in a question which I'd really like you to ask. Do you want me to remind you?
Thank you so much for the really insightful conversation as well. How can we best address healthcare staffing shortages in deprived areas? I'm from Thanet, so that's where I'm a district councillor, with regard to access to care in the community, and I'm talking specifically primary care access and carers.
Who do you want that directed to? Is that Angela?
Happy to start.
Yes.
Yeah.
Thank you.
So if I start with carers, as Sarah Louise said, many are unpaid and also don't have access to training. So that's something we have to pick up as ICSs and really support both, as I say, access to training. Funding is a difficult one because, as we've already heard, we don't have the ability to budget for unpaid carers currently. And I think also just thinking about support to people. It's very isolated. I think many people just have nowhere to go in terms of bringing together communities of carers with access to support around education and training is one thing that we've started off as a very small scale at the minute, and at the moment just thinking about looking after people who are dying at home in particular. So really wanting to scale that up eventually. And you talked about primary care, and if I talk about GP nurses, for example, and incredible actually. I mean, I'm an acute nurse by background, and so just really over the last year that I've got to see the work that GP nurses do and how important they are, and the sort of skill sets that they have. But and I think for the GPs in the room, I'm sure that you would say you wouldn't know what to do without your GP nurses. And so, as I've said, really thinking about recruiting and making it attractive for, making it a real career choice for people, because I suppose like GPs, they see families from birth to death. So there's a whole package around education, but I also think pay and conditions is another. It's very different for GP nurses. They're not on agenda for change like the rest of nursing, and that's something we really need to pick up.
Thank you very much. My name's Waka Shah. I'm a GP and I work at South East London ICB as well. I think this is probably the most important question and topic for the NHS at the moment. And so I was really intrigued by your views on a safe working environment. And I thought about psychological safety, and I thought about staff working in an environment where do they consider the environment to be safe? Do they, for example, feel vulnerable when they show initiative, when they do something outside of their role, which is helpful, but do they feel like they're going to be told off? Do they feel that they're able to challenge their leaders or ask questions of their leaders in good faith? do they feel empowered enough to do that? And so I think psychological safety is very, very important. It doesn't cost anything to implement. You'll be happy to know, Henry. But I think the thing we have to realise is that when people leave the NHS, they leave their roles permanently. They leave for a number of reasons, but money is not generally the number one reason why people leave. Yeah. So there's something in there about changing culture to allow people to be retained and feel valued. And I think we'd not solve the crisis, but I think we'll augment the situation considerably if we had some sort of policy along those lines.
So you're getting vigorous nods. Is that something, Sarah or Angela?
Yeah, so I completely agree with that. And I think some of the traditional ways of working, particularly in registered and maybe I would say the medical profession, you do get some deference there that doesn't enhance psychological safety, because people have traditionally thought, oh, someone's got a hand in my career and actually, I need to be careful here. However, if we look at what happened during COVID, actually we got rid of that. I think the danger is we've slightly moved back to our old way of working for a bit of comfort reasons. But I completely agree with you. I think the other thing that we are not good at and we need to be much better at is we're not anti-racist yet. And we say all these things about EDI, but they don't go far enough and we're not brave enough. And therefore that amplifies the lack of trust that we have with our communities. It amplifies the fact people don't want to work for us. And then you end up with this sort of vicious circle. So I think there is something about how do we become brave as leaders and start to really say what are the conditions that we want to create across the organisations in our integrated care systems. And that's not just our hospitals but our care homes and everything else. And when I was in South East London prior to coming to North Central, and we had a commitment of equity of experience regardless of employer. And I think that sort of language where you start to collaborate and start to say, well, why is it different for you? Acknowledging context and difference. So, for example, Great Ormond Street has a very young workforce. Most of over 63% of their workforce are under 30. It's quite a different environment to maybe Guy's and St Thomas's that have a lot of long-serving people. So you will have a contextual element, but I think we do need to be braver about, and I agree.
Could I just add to that? Just to say that there's also a really strong link between patient experience, safety, and staff, willingness to speak up. Yeah. So, and I think it comes from boards of organisations, leaders, as you've said, Sarah Louise, and really, not accepting anything but a culture that enables people to speak up.
Yeah, some great points made there, Waka. Thank you. I'm going to bring in the final question. I just wanted to comment on the diversity piece and, what you just said there, Sarah. IQVIA actually do the surveys, the patient and patient and staff surveys on behalf of NHS England all around the country, as you know. And that business about the diversity piece, it's evidence-based, it's really strong, and it was probably... It wasn't pay that came back, It was a real major issue in the feedback. So I think you've made a really good point. So the final question of today's event. Oh, I've got the counsellor over there. I'm going to bring her in.
Thank you. Shuli Porkes, Chief Medical Officer for Life Sciences for C2AI and Vice President of the Faculty of Pharmaceutical Medicine. The workforce plan talks about innovation as being a key thing, and I'd be really interested to hear how the panel see innovation and also collaboration with innovators, including commercial innovators, and kind of whether that's how you see that.
So panel, I'm going to give one of you that.
Okay, I'll have a go. If I'm honest, I think, I don't want it to sound too depressing, but I think we've really lost our grip on innovation, not just during the pandemic, but during the more difficult financially constrained years, and it's completely the wrong path to go down. We struggle to get the basics done sometimes when there's not enough money to go around, but it's incredibly short-sighted to lose that track. I'm lucky enough to work in a bit of North East London where my previous role was specifically around Tower Hamlets. We were one of the vanguards, and if you're able to carve out that headroom in your budget to to spend a bit of extra money on innovation, it pays back in massive dividends. So, I think it's something we need to get back to.
And I think we have heard a few very good use cases this afternoon on innovation and, and using different members of staff and using the R's team. So, 100%. So, final question goes to the councillor.
Yes, thank you. I just wanted to make a few comments. I'm sort of slightly moving away from the recent... it just occurs to me that we haven't yet mentioned LCRNs, local clinical research networks. And as a patient participant, I've been involved in these. And the reason I mention it is because, a lot of them are run by the NIHR. And we actually do target quite a few of the issues that have come up this afternoon. One of them being we make a point of setting up clinical trials and targeting commercial opportunities to work with commercial entities, pharmaceuticals and all the rest of it. There's sort of two aspects to the work that's done through the NIHR on this. One is actual being involved in clinical trials, monitoring clinical trials, being part of the design of clinical trials, and the other is the sort of what I've called the championship bit, where we actually help to recruit people, by being advocates for health research and all the rest of it. But an important part of the work actually involves making the literature that surrounds the clinical trial comprehensible, to somebody who isn't a medic. And that then has a wider thing in the question of digital literacy, because when you empower people by making all this information available and all the rest of it, you've got to worry about digital literacy in the sense of their ability to comprehend and assess what they're seeing. Yeah. That's another way in which you can get patients to help with that. I think what I'm trying to say is that patients are an underused resource in helping you as clinicians overcome some of the issues that you're confronted with.
So I think you've made these points, you've done it really well, and that LCRN and the work that the NIHR are doing is absolutely laudable. And Shuli Porkes, who's very modest at the back, is sitting quietly. She was the co-author of a report on diversity in clinical trials.
Yeah, that's another thing we tackle.
Yeah, and everything that you're saying about having the literacy and having it in lots of different languages is really, really important. And with the NIHR, companies like IQVIA and the life science companies, diversity in clinical research is absolutely front and centre. And I'm really, really pleased that the MHRA have now made it absolutely mandatory that you've got to be able to show the diversity in your studies. And interestingly, NICE, and WACA's very involved in this, in the submissions that go in from pharmaceutical companies to get a NICE approval, you've got to be able to show that you have reflected diversity in your population. So we're making baby steps. I love the points that you made about community champions. We had a health inequality summit a few months ago, and we had Paddington Life Sciences community talking about a roadshow they did with community clinical research champions. And community champions, not just for research, but for other things, to build that trust is the only way forward. But I am going to close it down there, because otherwise people will get very cross with me. So I'm going to wrap up now. I failed again. I'm 4 minutes over, and I can't even blame Richard. So look, thank you all. Of course, we did lose people throughout the day. What I was really surprised about today is how many people have travelled from a long way. So from Portsmouth, from Doncaster, and people have stayed. And I really thank you for that. I think we've probably lost about 30% of our audience, which I'm absolutely delighted that we've kept all of you. And I think that is a reflection of the kind of agenda we put together. I said at the outset, I wanted this to be about your meeting. I hope you've taken new things away. I hope you feel it's been, a really good use of your time today. I would encourage you to stay and have a drink, do that networking, talk to somebody you've not talked to before, make a new friend, and please do feedback to us how you felt about today. And for those online, if you're still online, thank you very much for staying with us. So thank you all, and please go and have a lovely drink, and thank you all very much again.